When we talk about a cyanotic congenital heart diseases, and the ones that have a septal or endocardial cushion defect, they all are going to have wide splitting of S2. But if this splitting is fixed and there's a systolic ejection murmur, you're either going to have ASD or endocardial cushion defect. If it's not fixed, if the wide splitting of S2 is not fixed, and you have a hollow systolic murmur, that means that you have a VSD, or ventricular septal defect. So for the ASD, the most common cause is an ostium secundum defect. As a child, earlier in the child's life, you're not going to have many symptoms because this is a low flow shunt, and of course it's a left to right shunt. In an older child, you're going to have exercise intolerance. And the main kind of diagnostic test results in ASD are an ECG or EKG showing right axis deviation, and a chest X-ray showing right ventricular and right atrial enlargement. As far as endocardial cushion defect, one thing you need to remember is the most important thing you must remember is that trisomy 21 patients have a high risk for ECCD than the general population. So in this ECCD, it's basically an ASD plus a VSD plus AV valve abnormality. The symptoms of ECCD present much earlier than ASD, and it's basically going to be very severe, like heart failure, and failure to thrive, and infections. As far as diagnostic tests go, there's going to be severe cardiomegaly on CXR. And on EKG, there's going to be signs of left ventricular hypertrophy and right ventricular hypertrophy. Now on to VSD. So this is the most common congenital heart lesion. It can be membranous or muscular, but most are membranous. This one is particularly susceptible to Eisenmeyer's, so that needs to be watched for. Most are asymptomatic, especially if the pulmonary artery pressure stays low. But if you're basically going to see left ventricular hypertrophy on EKG, and cardiomegaly on chest X-ray. And you reached the end of my lecture. So now let me organize these diseases by severity, and also I'm going to include some of their subtypes. So probably ASD first, then muscular VSD, then membranous VSD, and then endocardial cushion defect. So let me just draw an arrow. So you're increasing severity. Okay. So as you go down this list, you're increasing in severity. So ASD oftentimes closes spontaneously. And oftentimes, even if it doesn't close spontaneously, you don't see any symptom till, the patient is in their 20s or 30s. So you would do some kind of surgery or transcatheter device for symptomatic people with ASD. For a muscular VSD, there is a high likelihood of spontaneous closure. So, like the ASD, it is likely to close on its own in the first 1 or 2 years of life. As far as a membranous VSD, you have to look at a couple of things. The pulmonary artery hypertension and the size of the defect. So that really determines whether you go for medical management or surgical management. And usually you would end up going for surgery in the first year. As for endocardial cushion defect, you need to operate. And this has to be done in infancy. So when the patient is an infant. We're not going to really look for levels of pulmonary artery hypertension because this in itself is very severe. So you've reached the end of my video. Please subscribe to my channel.